I'm Dr. Salman, vascular surgery resident from Narayana Health, Bangalore. And the topic allocated to me today is a basic overview of renovascular disease, the epidemiology, the natural progression of the disease, and the causes, and basic history and examination, and what investigations are to be done in renovascular disease, and about medical management of renovascular disease. So let's start with anatomy, basic anatomy of the renal blood supplies. The renal arteries are paired arteries that arise from the anterolateral aorta, approximately at the level of the intervertebral discs of L1 and L2. They're approximately 5 to 6 millimeters in diameter. The right renal artery is longer than the left renal artery, and the left renal artery arises slightly higher than the right renal artery. The right renal artery courses posterior to the IVC and the renal vein and the head of pancreas and the second part of the duodenum, while the left renal artery courses posterior to the renal vein, splenic vein, and the body of the pancreas. And going to the branches of the renal arteries, there are inferior suprarenal arteries, which mainly supply the adrenal glands. And they also give off small branches to the ureter, to the perinephric tissue, and to the renal capsule. And the renal arteries end near the hilum of the kidney by dividing into the anterior and the posterior branches. The posterior branches supply the posterior part of the kidney, and the anterior branches give rise to the segmental branches, and which again divide into the lobar branches which supply the pyramids, and then the interlobar branches which become the arcuate branches which enter the nephrons and run as the interlobular branches, and which enter the glomerulus as the afferent and the efferent arterioles. The renal artery anatomy has a few variations. The renal arteries are single in approximately 70% of the cases, and accessory renal arteries may be present in 30% of the cases, and the accessory renal arteries are mostly present below the main renal artery. The origin of the renal artery can also be variable. It can arise from the bifurcation of the aorta. It can arise sometimes from the common iliac artery, or it can arise from the internal iliac artery. The renal arteries may sometimes undergo early branching before they reach the hilum of the kidney. Very brief interview regarding embryology of the renal arteries. The kidneys ascend from the pelvis into the lumbar region, approximately into along the 6th to the 9th week of embryogenesis. And during ascent, they are supplied by multiple transitory vessels, which all originate from the aorta, and most of them disappear, and the renal arteries persist from the lumbar regions. So this can be one of the causes for persistent renal arteries. And this will be dealt later on by my colleague in her class, which is on developmental abnormalities. Now, going on to basic physiology of the renovascular disease. The renovascular disease is driven mainly by the system called the renin-angiotensin-aldosterone system, which helps in the regulation of BP and fluid balance. The main driving force regarding the problems which arises from the renovascular disease or renal artery stenosis is that there is an increase of the renin production from the juxtaglomerular cells of the juxtaglomerular apparatus. And what are the causes of increased stimulation of renin secretion? There are multiple causes for this. It can either be due to decreased sodium that is sensed by the cells in the distal convoluted tubules. Secondarily, it can also be due to reduced perfusion pressure in the efferent arteriole. And it can also be due to sympathetic stimulation of the juxtaglomerular apparatus by beta 1 adrenoreceptors. Now, renin acts on angiotensinogen, which is produced by the liver, and converts it to angiotensin 1, which is acted upon by the angiotensin converting enzyme, which is produced by mainly in the lungs and a bit in the kidneys, and converts angiotensin 1 to angiotensin 2. Angiotensin 2 is the physiologically active molecule, and it affects its actions by two receptors, angiotensin receptor 1 and angiotensin receptor 2, which both of them are G protein coupled receptors. And mainly the action is mediated by angiotensin 1. Now, angiotensin 1 receptors have different arterioles on different body system. So it acts on the arterioles to cause vasoconstriction. And this is facilitated by increasing intracellular calcium in the cells. Angiotensin 2 acts on the hypothalamus, which causes increase in antidiuretic hormone secretion, and this causes increased thirst. It also acts on the sympathetic nervous system to increase noradrenaline, which itself is a vasopressor and increases the BP. It acts on the kidneys and causes afferent and efferent arteriolar vasoconstriction. It also increases the sodium reabsorption. It also acts on the adrenal gland to produce aldosterone from the zona glomerulosa, which causes increase in sodium absorption, and due to the sodium potassium pump, it causes decrease in the potassium in the cells and causes hypokalemia. All the actions are basically to increase the intracellular volume, intravascular volume, and this volume is sensed by the walls of the atria, and the whole renin angiotensin aldosterone system is inhibited by a substance called atrial natriuretic peptide, which is secreted by the walls of the atria in response to stretch of the atria, which means that the patient is adequately fluid loaded. And because of all these changes, chronic structural changes occur in the blood vessels, like wall thickening, stiffening. And these are due to long-standing hypertension and the mitogenic effects of the angiotensin 2. So this is the basic physiology of the renovascular disease. So what is renovascular disease? It is basically a range of disorders that affect the renal artery structure and the kidney blood flow. And the main effects due to this are hypertension and the loss of renal excretory function. So going into the basic history behind renovascular disease and renovascular hypertension, in the late 19th century, renin was discovered. In 1930, Goldblatt attributed hypertension to renal artery stenosis, and he treated it by removing the kidney or by treating the stenosis. In 1938, a child with an ectopic kidney who had severe hypertension was treated by removing the ectopic kidney, and his hypertension was treated. So because of all these experiments, nephrectomy as a treatment for hypertension, which was not responding to medical treatment, was popularized, and it remained popular for a few decades. In 1954, Freeman undertook the first renal artery reconstruction. In 1970, balloon angioplasty was popularized by Grunitz et al. And approximately a decade after this, balloon expanding stents were introduced and renal artery stenting was popularized. So going basically into the epidemiology of the renovascular disease or the etiology of the renal artery lesions. So 80 to 90% of the renal artery stenosis is because of atherosclerotic disease. And a few features of the atherosclerotic disease are it is more severe at the renal ostia, but it can also occur at the smaller branches. It is usually contiguous or continuous along with an aortic plaque. It is heavily calcified, hence it is resistant to balloon dilatation alone, it requires renal artery stenting. Another cause is fibromuscular dysplasia. This, on an angiogram, usually presents with web-like stenosis or the classical string of bead appearances due to the stenotic areas and the aneurysmal dilatation between them. And the third cause can be due to dissection, which can be either spontaneous or it can be secondary to trauma or iatrogenic, or it can be continuous along with an aortic dissection flap. And dissection can cause thrombosis or infarction of the kidneys, and it can extend into the renal parenchyma. And if it extends into the renal parenchyma, then treatment is a bit tough. And once the dissection settles, it can cause strictures or aneurysmal dilatation of the renal vessels. And the other causes are multiple arteritis and congenital abnormalities or the mid-aortic syndrome. Going into the pathophysiology of the renovascular disease. So the hypertension in the renovascular disease, as I explained previously, is mostly because of the renin-angiotensin-aldosterone mechanism. So I will not go into that again. And the second part, which is there in renovascular disease, is the ischemic nephropathy. Ischemic nephropathy basically presents as loss of renal excretory function. So if there is an acute block to the blood supply of the kidneys because of the almost nil collateral blood flow to the kidneys, infarction can occur within a few minutes to hours. And if there is chronic hypoperfusion to the kidney itself has intrinsic adaptive mechanisms because of the efferent arteriolar vasoconstriction and the renin-angiotensin-aldosterone mechanism, and it can adapt to a wide range in variation of blood pressures. But if those mechanisms are overwhelmed and the hypoperfusion is prolonged, then it leads to a decrease in kidney function. And this is presenting mainly as decrease in the glomerular filtration pressure and ischemic damage to the tubules of the nephrons. And chronic angiotensin 2 or aldosterone excess in the body causes an increase in the profibrotic cytokines and the growth factors. For example, transforming growth factor beta, platelet derived growth factor, or nuclear factor kappa beta. And these growth factors, due to a wide range of mechanisms, in the end cause glomerulosclerosis and tubulointestinal injury of the kidney. And atherosclerotic lesions themselves can release microemboli, which can go into the distal smaller branches and themselves cause ischemic damage to the kidneys. And unilateral RAS, due to the associated hypertension along with that, can affect the opposite kidney because hypertension itself causes changes in the blood vessels. And another thing which we need to remember is that the causes of chronic kidney disease is often multifactorial, and they are overlapping causes of renal artery stenosis and chronic kidney disease. Going into the basic epidemiology, that is basically the study of the disease and its natural progression and the prevalence and the ways of prevention and treatment. So the prevalence, going into the prevalence of the renovascular disease or renal artery stenosis, Hansen et al. Almost 870 patients were screened by renal Doppler ultrasound. And these patients were picked up from a large group called the community health study. And they were patients who were independent and who did not have a pre-known hypertension or disease. In that, almost 7% of individuals had renal artery stenosis. And out of the 7%, 28% of the individuals were normotensive. Many a times, renal artery stenosis is picked up incidentally and it is asymptomatic. And the reasons of which being the arterial stenosis is hemodynamically inconsequential. The adaptive responses to the reduced blood flow are good enough to maintain a glomerular filtration. Or the reduced blood flow has already damaged the kidney so much that the renin release, which drives the physiology behind renal artery stenosis, is not enough to cause the disease. And there are a lot of confounding factors between chronic kidney disease and renal artery stenosis. Diabetes, hypertension itself can cause atherosclerosis and other factors. So there are a lot of confounding factors between both of them. And the thing is, there is no test which can surely say 100% that if a particular lesion is detected on imaging of any renal artery stenosis, is this the 100% cause which is driving the hypertension and the reduced kidney function? There is no test which can talk about this as a surety. So basically, what is meant by this is that imaging alone, if you consider as a criteria to diagnose renovascular disease, it overestimates the prevalence of the disease and overestimates those who can benefit from intervention for renal artery stenosis. There have been a few other studies also. Schwartz and White conducted an autopsy in 154 patients. 6% of them in age group less than 55 had renal artery stenosis, and 40% in age group of greater than 75 had renal artery stenosis. But these studies were criticized because the major cause of death in the United States where the studies were conducted was itself an atherosclerosis, which was the major cause of death. So there was a bias towards atherosclerotic disease. And angiographic screening has also been used as a test to see the prevalence. And 22% of the people who underwent cardiac catheterization had renal artery stenosis. 40% of patients with peripheral arterial disease who underwent imaging had renal artery stenosis. And 27% of those who underwent imaging for carotid artery stenting had renal arterial stenosis. And natural history of the disease. So knowing the natural history of the disease is important because renal artery stenosis drives hypertension, decreased kidney function. It is also can contribute to cardiovascular mortality and death and progression to dialysis. So in this, progression of the disease can be anatomical progression, it can be a functional progression, and there is associated morbidity associated along with progression of the disease. So anatomical progression, there have been studies which have just considered arteriography. In this, 11 to 35% of those which were managed medically had a progression in their renal artery stenosis. And Zeiler et al. Used renal Doppler ultrasound to study the anatomical progression for this of the stenosis. And in them, almost normal kidneys alone 8%, and he used a cutoff value as a 60% stenosis. And 43% of the people had less than 60% stenosis. Over a 3-year period, they progressed to a high-grade stenosis. And 7% of the individuals who had greater than 60% stenosis went on to occlude their renal arteries. And he found the associated factors which were associated with increase in progression of the disease to be the age, advancing age, uncontrolled hypertension, smoking, and a female gender. And functional progression. Functional progression is studied by the rise in creatinine and the fall in EGFR. But rise of creatinine has been contested because greater than 50% of the nephrons have to become dysfunctional for the creatinine to rise. So another parameter which they consider to study the functional progression of the renovascular disease is that kidney size. And a few studies regarding this, Schreiber et al. Showed that a significant loss of function was there regardless of the progression of renal arterial stenosis. And Dean et al. Studied patients with renal arterial stenosis plus hypertension, and they found that 46% had a rise in creatinine and 37% had a decrease in size. And Capps et al. Studied patients with greater than 60% of renal arterial stenosis, and over a period of 2 years, 21% of the patients had a decrease in size of the kidney of greater than 1 centimeters. And other studies have shown that around 7 to 12% of the patients with renal arterial stenosis on medical management progress to dialysis over a period of 3 to 4 years. And in the previous study, which I described, the community health study, in that 4% of individuals without any hypertension had progressive renal dysfunction. And 4% of them who had renal arterial stenosis. So 4% of the 7% had progressive renal dysfunction of the. And associated morbidity along with the disease is increased risk of cardiovascular events, stroke, and progression to dialysis, in which in some studies, which is approximately 10 to 18% of the patients with renal arterial stenosis. So going on a bit to the clinical presentation of renovascular disease. So history-wise, most of the renal arterial stenosis, which are referred to a vascular surgeon, have been found incidentally. Patient has been imaged for some other disease, some other factor, and they have picked up the renal arterial stenosis, and then they have referred it to a vascular surgeon. There can be a few targeted referrals. For example, severe hypertension, which is unresponsive to 3 or more classes of hypertensive drugs, or renal insufficiency, which is unexplained or which is associated along with risk factors of renal vascular disease. Or the referral can also be due to the fact that previously some renal arterial stenting has been done or any other procedure has been done, and for surveillance also patients may be referred. And all children with unexplained hypertension should be screened for renovascular disease and renal artery stenosis. And the hypertension which is associated with renal arterial stenosis is usually very severe. For example, some studies have shown that the average mean BP which they have recorded is around 200 systolic and 100 diastolic on while the patient has been on 3 or more drugs. And most important thing which we need to see is that there should be a severe hypertension along with risk factors of atherosclerosis. And renal dysfunction with moderate hypertension, such patients usually respond poorly to revascularization. So other causes of essential kidney disease or other causes of medical kidney disease should be ruled out in them. And patients, because of the gross hypertension which is there, their ventricular walls become thick and they have a reduced diastolic relaxation of the ventricular walls. And such patients can present with flash pulmonary edema. Patients can also present because of the increase in the blood pressures, they can be third space losses. So patients can present with edema, including edema in the brain, headache, visual disturbances, in a very few rare cases, stroke or even intracranial hemorrhage. So going on to the examination of patients who present with renal arterial disease, the first thing which we need to examine is the BP. As I said, the BP in renal arterial stenosis or renovascular disease is usually very high, around 200 systolic or 100 diastolic, even on multiple drugs to control the hypertension. There can be edema, there can be abdominal bruise if there is any other symptom associated. They can have associated peripheral arterial disease. And if children present to this, to rule out coarctation, children may have differential pressures in the upper limbs and the lower limbs. And a few laboratory tests to be done in renovascular disease is basically a urine analysis to see the proteinuria, the electrolytes, the creatinine and the blood urea nitrogen, HbA1c to rule out concomitant diabetes, ECG which shows a strain pattern and left ventricular hypertrophy, echo which shows increase in the LV thickness and diastolic dysfunction. And another main cause for doing laboratory tests in renal arterial stenosis is to rule out the other causes of hypertension, which can also present with very severe hypertension. And the two main causes in these are hyperaldosteronism, which is Crohn's disease. And these patients can present with spontaneous hypokalemia with the potassium of less than 3.5. and they can have a sudden drop in serum potassium after diuretics have been started for them. And another cause to be ruled out in these patients can be a pheochromocytoma. In this, imaging is done to rule out any mass adrenal tumor. And these patients with pheochromocytoma usually present with episodic hypertension or severe headache, which is associated with any stress or any strenuous activities which they undergo. And the test to rule out pheochromocytoma, the best test to rule it out is 24 hours urinary metanephrines. And going on to diagnostic imaging in renovascular disease. So I will be mostly talking in terms of renal duplex ultrasonography. The RDU, renal duplex ultrasonography, is basically the primary tool for screening of renovascular disease and renal arterial stenosis and in follow-up. So the basic advantages of RDU is that mainly there is no radiation or contrast exposure. The test is rapid. It can be easily available. Does not require very advanced machines. It is non-invasive. It is accurate in the hands of good radiologists or good examiners, and it is reproducible. The major disadvantages of renal Doppler ultrasound are that it is operator dependent and it is technically demanding, and it has limited use in picking up other causes of renal arterial stenosis like fibromuscular dysplasia or dissection. And there are multiple patient factors which affect the effectiveness of the renal Doppler ultrasonography. For example, obesity, bowel gas, or advanced CKD with shrunken kidneys. These are not very good patient subgroups for renal Doppler ultrasonography. So basically, what do we see in the renal duplex ultrasonography? How is the procedure done? So first, the perirenal aortic peak systolic velocities are recorded. In each renal artery in the proximal, mid, and distal renal artery, the peak systolic velocities are recorded. The velocities are also recorded in the renal parenchyma in the superior, mid, and inferior pole. And in the end, each kidney size is recorded. So basically, in many centers, the cutoff for renal arterial stenosis is around 60%. So they basically speak in terms of greater than 60% stenosis or less than 60% stenosis. So a peak systolic velocity of greater than 200 centimeters per second along with post-stenotic turbulence is usually taken off as a cutoff value for a greater than 60% stenosis. And another parameter which they consider is the ratio of the renal artery to the aortic peak systolic velocity. And any ratio which is greater than 3.5 is, can be taken as that having a greater than 60% stenosis in the lesion. And the other imaging which can be done at the hilum in patients with renal arterial stenosis which have poorer blood flow at the hilum can be a blunted waveforms with a delayed systolic upstroke which is greater than 100 milliseconds. But this test has a relatively lower sensitivity. And another test which they consider is the resistive index. So this basically is a predictor of renal parenchymal disease. So the resistive index is the ratio of the difference of the peak systolic velocity and the end diastolic velocity divided by the peak systolic velocity. And if post-intervention the resistive index becomes less than 0.8, then patients are considered to have better outcomes to revascularization for renovascular disease. So this is about basically about renal duplex ultrasonography and the practical aspects which are to be considered in this. So moving on to other investigations, the CT and the MR angiography. So the CT angiography The basic advantages are it provides an information regarding the surrounding tissues about the renal parenchyma, any other masses, any other issues, and it gives an idea about the aorta and the surrounding anatomy. It is non-invasive, it is widely available, it is quick to perform. The image formatting in this is less technically demanding, and a good 3D reconstruction, an accurate 3D reconstruction of the image can be performed after a good CT angiography. The disadvantages basically are radiation exposure and the use of iodinated contrast. And as many of our patients are already having renal dysfunction, this can cause contrast-induced nephropathy and worsening of renal failure or even dialysis dependence. So MR angiography is the other modality. The major advantage is that there is no ionizing radiation and no iodinated contrast which is used in MR angiography. The disadvantages basically of MR angiography are long scan times. There is less spatial resolution. Many of the patients have implants and the MRIs are incompatible to implants or to pacemakers. And if we are using contrast enhanced MR angiography, gadolinium is the contrast which is usually used, or gadolinium based contrasts are used. And a major complication in patients with reduced renal dysfunction is a nephrogenic systemic fibrosis. And MR angiography overestimates the stenosis. Hence, MR angiography basically has an excellent negative predictive value for renal artery stenosis. So another imaging modality is the digital subtraction angiography. It provides excellent human morphology in high resolution. And the other major advantage is that it allows endovascular intervention simultaneously. So the basic disadvantages basically are puncture site complications, high dose of radiation both to the patient and the examiner, uh, and 2D information. It does not give a 3D picture. It is more labor intensive. It requires a specified team and contrast exposure, iodinated contrast. So DSA nowadays is basically reserved in those patients which are planned for intervention. So going on to functional studies. As I previously mentioned, there is a lack of one particular test which can say that these patients, if intervened in, will respond to revascularization. So they have designed multiple studies which give an idea regarding the kidney function, which can be helpful in predicting which patients will benefit from revascularization. So two studies in this are radionuclide renography, which is also called captopril renography. In this, basically, radio-labeled 99 technetium mercaptoacetyl triglycine. This is the this is the agent, radioactive agent which is used and which is excreted by the kidney, and the excretion can be read by the radioactive cameras. So basically what is done in this is that an ACE inhibitor or an angiotensin receptor blocker is given to the patient to block the response of angiotensin 2. So as I said previously, basically patients with renal arterial stenosis have their whole physiology driven by angiotensin 2. So in this, they are basically trying to block the response of angiotensin 2. So once angiotensin 2 is blocked, so the excretion of this molecule in the kidney, which is affected by renal arterial stenosis, causes a decrease in the excretion, because the renal blood supply in those patients was being maintained because of the angiotensin 2. And once that effect has gone down, so there is decrease in the excretion in those kidneys which are affected by renal arterial stenosis. And the increase in the angiotensin 2 causes vasoconstriction in the opposite kidney. So there is reduced blood supply when there is angiotensin 2 excess in the normal kidney. So once that effect has been blocked, there is an increase in the excretion of this molecule by a normal kidney. So this gives an idea about how effective is the blockage of the renal, how effective is the blockage due to the renal arterial stenosis. And so a normal radionucleotide renography effectively rules out renovascular hypertension. And the drawbacks of this test are that it is less accurate in severe azotemia or in small poorly functional kidneys, because already the excretory response of those kidneys has already been damaged. So another test which is done is the renal vein renin assays. So because renovascular hypertension causes excessive renin production, so the affected kidney should produce excess renin. So basically in this, the IVC is canalized and one catheter is parked in the IVC and one catheter is parked in each renal vein, and the blood is drawn selectively from the catheters and the renal vein renin levels are measured. So a cutoff value for this test is the renal vein renin to systemic renin ratio of greater than 1.5 is significant. The basic disadvantages of this test is that it is invasive, it is complex, and it can be altered by multiple variables, including the drugs which the patient is on for hypertension. And if there is bilateral renal arterial stenosis, so this test has no use because both the kidneys are involved. And many centers basically mainly use this test when they are deciding on open revascularization. So going on to the medical management of atherosclerotic renovascular disease. As renal arterial stenting was popularized, so and multiple centers started using prophylactic renal arterial stenting whenever they found a lesion uh, which they considered to be significant. So there were multiple trials, including the STAR trial and the Astral trial, which were conducted in Europe, and the more recent Coral trial was conducted in North America, which studied the effects of medical management alone versus those effects versus those who were treated with stenting. I think my colleague who will present the endovascular treatment of renovascular disease will shed more light on the trials. So I'm not going into the details of the trials. So basically, most of these trials have come to the conclusion that most of these patients can be managed medically, and there is not much significant difference in those patients which are managed medically and which are treated with renal arterial stenting. So basically, the conclusion is that the prophylactic renal arterial stenting or stenting just because a lesion has been picked up on imaging can largely be avoided, and most of the patients should be managed medically initially. So in the medical management of atherosclerotic renal vascular disease, the first thing which is most important is the primary prevention, which is risk factor control by exercise, smoking cessation, nutrition, and weight loss. Lipid levels should be monitored, and LDL cholesterol and triglycerides, if they are high, should be treated and controlled. Statins and antiplatelets should be started for the patients. Statins are protective, have shown to be protective against progression of renal arterial stenosis, and they also protect against restenosis after stenting. And antiplatelets, because most of the patients with atherosclerotic renal arterial stenosis also have concomitant cardiovascular disease or cerebrovascular disease or peripheral arterial disease, and antiplatelets are effective or helpful in prevention of those. And as I said, the renal dysfunction can be multifactorial, so we should rule out the other causes of renal dysfunction and control the other factors. And the basic treatment after all this is hypertension control. So the level of BP which is considered to be acceptable in patient is, it should be less than 140 systolic by 90 diastolic, or if there are associated factors like diabetes or renal dysfunction, then the threshold comes down to 130 by 80. And in hypertensive control, again, lifestyle modifications like reduction in salt in the diet, reduction in alcohol intake, and stress modification, stress control play a very important part. So because the renin angiotensin aldosterone mechanism basically is the driving force behind this, so ACE inhibitors or angiotensin receptor blockers are the first line choices of these. But in patients with bilateral renal arterial stenosis, because the angiotensin 2 and the renin, which is secreted by the kidneys, is the driving force behind maintaining adequate renal perfusion. So these ACE inhibitors or ARBs should be cautiously used in patients with bilateral renal arterial stenosis, and creatinine monitoring and EGFR monitoring should be done in these patients, as they can cause a sudden decrease in the EGFR. So other first line agents which are used for BP control are thiazide diuretics, calcium channel blockers, and beta blockers. And even after this, if they are not, the BP is not controlled, second line agents like hydralazine and clonidine can be used. So basically, a general consensus, what they say is that even if there is no adequate BP control, even after 3 classes of antihypertensive drugs, or the patients have had some some cardiovascular compromise like flash pulmonary edema, so then those candidates are the ones who should be considered for surgical treatment or endovascular or other management for the renovascular disease. Thank you.